Wonderful, thank you.
So, Nungri Nungi, everyone. Paul Worley is my name. Here on Natajerry Rui in Murray Bridge or Pomerunk, and Nilniandu to the race grand round for this week. It's an opportunity for our health service to hear from the best around the world and to see how we might be able to collaborate and work with others to improve the services that we provide and the services that they provide. We have a great privilege today to be hearing from one of the iconic models in Australia of innovation around the integration of general practice and hospital medicine, which of course is right at the heart of the rural generalist approach to healthcare. And Dr. David Walker has lived and been part of this experience for the last 17 years. And he's now the Executive Director of Medical Services for Central West Health. So he is now leading the next steps in this innovation. We've got to know David, particularly through the discussions that have been happening around a single employer model nationally that we are also piloting here in Riverland, Mallee Coorong. So David, welcome, and we look forward to hearing all about the Longreach model.
Thank you very much, Paul. That's a very, very kind introduction. And look, I think, so by way of quick introduction, as Paul said, I'm the Executive Director of Medical Services here in the Central West. I'm a rural journalist by trade, but making the kind of transition over to medical administration. I've gone back to being a registrar this year. I'm back doing my medical administration training. I've been EDMS for about 6 years and but Director of Medical Services in Longreach before that. And my wife Claire is also a rural journalist and lives here. We've raised our kids here, and most of them are off at boarding school at the moment. So, look, my biggest risk is to talk too much, and I'm really happy to take questions. I want to try to give some time for questions. I'm also happy to field questions out of session. I'm pretty easy to find. So if you need to ask anything, please let me know. To reiterate Paul's acknowledgement of country, I'm here on Inangai land, although the Central West, as you'll see shortly, is a very large place, and we've got multiple language groups within our patch. And I'd like to acknowledge the living culture that sometimes the lands of waterways for tens of thousands of years. So, as I kind of alluded to, we're the biggest health service in Queensland, and I've got a map on the next slide. We cover about 20% of Queensland's land mass, but the smallest by population. So we've only got about 10,500 or 11,000 people in the health service. I guess what's unique about our model, and I'll kind of explain how we got there because it didn't happen overnight, is that we've become the provider of last resort for general practice. There's currently no private general practitioners left within the Central West, no true private general practices. But as you'll see, to the general population, we really don't want them to see anything different. We want them to go to general practices that look like general practices, that feel like general practices, and see doctors who work as general practitioners. And so for us, it's a really big deal, and it's a really big part of our model. But the reality is at the moment is that the health service runs 5 accredited general practices across the whole patch. Now, this model is often called the Longreach model, although to be honest, it's across the whole of the Central West now. We're trying to use a kind of a single practice model as the kind of nomenclature. It's probably a good segue to honour the person who was probably the father of this model, which is Dr. David Rimmer. David was my predecessor as EDMS, and most recently was my Director of Clinical Training, just retiring in April. He was honoured for a lot of his work in rural medicine and rural workforce development with a King's Birthday honour on Monday. He received an Order of Australia Medal. And so we were very proud to see him honoured in that way, and it was really fitting that he got that award. That's us. We're out in the middle. It's got its own issues. In many ways, a lot of our patients down here in the Western corridor are actually closer to you guys in Adelaide or you guys in South Australia than to us, than to our major cities. And so it has implications, as you would all know, with patient transport, with retrievals, has impacts in just providing general practice care to some of those places that are just so far away. And so that whole area is about 395,000 square kilometres. So what is our model? The models are all SMO. The doctors are all SMOs. So I mainly talk about our seniors, but our seniors are very much supported by junior doctors, most of which rotate in from the cities, from our big feeder hospitals, but some of which we employ ourselves and are probably some of the new frontier. The revenue that we gain from Medicare billing is not generating activity under our service agreement. And so we don't receive any funding from the state government to run our general practices. That's a point of ongoing negotiation and a bit of a sticking point, obviously. But we were faced with a situation, 10 or 15 years ago with, well, how are we going to provide general practice care when these practices start to close? So under the Queensland Health Award, and this is one of the things that probably sets Queensland apart in a way, is that our SMOs have a granted private practice agreement. And they exercise that to work within the practices. Most of them assign their revenue to the health service, but there is also a clause that some of them are able to retain their billings. And as of January last year, a handful of doctors across the patch started to exercise that right. And we're in the process now of seeing what effects that has on our revenue generation, on the kind of activity we generate during the practice throughout the practices. I should specify, and I probably did say this in my SEM talk back in March, but all of our hospitals and private health centres are separately registered as COAG 19(2) exempt sites. So they're a little different to the practice, and we provide outreach to a lot of those small clinics from our major hubs. So the drivers are probably fairly straightforward. MSRPP might be an acronym not familiar to many of you. It's a very traditional Queensland employment model, and I'm not sure if something similar exists down there as well, but it's where a doctor has a right to set up shop in a town. They're provided with a retainer, a fairly modest retainer, to look after the hospital, and also have a right to private practice. So that stands for medical superintendent with right to private practice. And so most of our positions were very traditional. And when I started here back in 2006, those employment structures still existed across most of the Central West. Usually older doctors getting close to retirement by that point when we arrived, often with a stay-at-home spouse, and often male, who would work under that model and would provide, usually as a single doctor, would provide 24-hour on-call services throughout the whole year, with relief from junior doctors who are often kind of thrown in the deep end from big places to come out and relieve and run general practices. And we just felt that it was a really it was an unhealthy model, especially with regards to supporting our juniors. We didn't really think it was certainly just not cool these days to do that to anyone, let alone junior doctors. But we also found that our seniors just weren't prepared. It's just a model that wasn't attractive to anyone anymore. Coupled with that was the market failure of general practice, which we're starting to see across Australia. And as I mentioned in my intro, there's now no remaining private practices within the Central West. Look, I'm not going to go into depth as to why that happened, but because there's lots of different factors, Medicare being one of them, but also the overheads of running essentially a small business in a country town. But one by one, our practices shut. There was also a rapid rise in locum costs. This kind of actually came at a point in time when there was the Dr. Patel scandal in Bundaberg here in Queensland, and it kind of changed the process for credentialing and for employing doctors, but it was coupled with a much higher salary, especially for locums. And private practices just couldn't compete with Queensland Health with regards to getting locums into their practices. A lot of those senior doctors that I mentioned started to retire, and we're in a situation where trying to get the next generation of doctors to start. We're still a little way away. The rural generalist pathway had just started in Queensland. And I was actually, myself and Claire were actually in this kind of in-between era where there was hardly any doctors training specifically to be rural doctors, and there wasn't a dedicated pathway in Queensland for it. And the rural generalist pathway, from memory, started in 2011. The other thing and so as a result, and just as an example, I think there was only 4 doctors from my year who were practicing rurally, and there's only 1 doctor from Claire's year who's a year below me practicing rurally, and that's her. Setting it up was tricky. There was quite a lot of barriers. There really wasn't a precedent for public to private supply at the time, certainly not within the general practice setting. There was quite a few precedents for private outsourcing, including locum agencies providing services, but the other way around was something that we had to bridge. There was lots of, as you can imagine, there was lots of complex legal, contractual, financial issues. One of the practices decided to stay on as a management kind of company with none of their active principals involved in delivering care, but with the health service providing the doctors within that structure. And it was very complicated to negotiate that legally. But we got there in the end. We obviously needed to comply with the Health Insurance Act. We obviously needed to deal with the fact that all of the practices had evolved independently. And so because they were all single practices owned by single doctors, they all had different structures with regards to their management, their infrastructure, their staffing, etc. And so we've tried to standardize that over the last 2 or 3 years to really make sure we've got a standard approach to how we provide general practice care. As I touched on, there's no dedicated service agreement funding from the state government. That obviously means that we need to try to provide outsourced revenue from within the practices themselves. There was also 2 legacy patient databases. So they were both medical director databases. And it was an enormous headache from an ICT point of view to try to work out how to merge those databases. The solution actually ended up being to switch to best practice. Obviously, as a rival company, best practice is fairly used to kind of pinching, for want of a better word, databases from other platforms. And so we've merged to a single best practice database as of December of last year. The centralised general practice formed as a business unit within our health service structure, and I'm the executive sponsor of that unit, and also have medical workforce in my portfolio. I still work clinically. I'm actually in my consulting room this afternoon, and I've got patients directly after this. Standardization of approach. During COVID, 2 of our practices switched to bulk billing as part of their approach. And we actually, in January of last year, we actually switched all of our practices back to mixed billing. We did it in a very considered way. We actually benchmarked against similar practices. We consulted with the community. And interestingly, and we still have a very high threshold for private billing. But interestingly, we've had no complaints at all from the community since we switched to mixed billing. Of course, with the proposed changes to Medicare and the incentives for bulk billing, we have we've got a decision to make as to whether we switch back, which I guess is a philosophical thing versus a financial thing, to going towards all bulk billing from here on in. And ICT, to say that ICT was an ongoing challenge is probably understating the fact. It's a very challenging thing to manage using kind of Queensland Health ICT infrastructure within private practices. So I guess what we found for the medical officers is that it really provided reasonable on-call. I was reminded of this last night, and the collegiality of having, just not being on your own in an emergency. And I was reminded of that last night. I certainly don't do as much on call as I used to, but last night I happened upon an enormous trauma that was being worked on within Longreach Hospital. And, reflected on the fact that we had 3 senior doctors, 2 junior doctors, we had medical imaging, and we had all of our wonderful nursing staff at this patient's attendance. And it just reminded me that probably only 15 or so years ago, there would have probably been one senior doctor and 1 junior, plus as many nurses as they could muster up. So to get to that point where we've got that many staff available to support each other in an emergency is really, really wonderful. And it's appreciated by the guys. It allows them also to have fractional appointments. And across my kind of complete FTE of about 26 FTE, I think there's only 4 or 5 of us that are full-time. The remainder of the doctors are part-time. And so I very much bang on about differentiating between headcount and FTE when I do my workforce planning, and when I take submissions to my finance department, because it's really important. Queensland Health Benefits, similar to the SEM models, Queensland Health Benefits continue training, but I guess differently to the SEM pilots as they're being undertaken, is that our benefits continue post-fellowship. The doctors get access to both their general practice, which is where they can train and have supervisors and be in accredited general practices, but they also get to provide their advanced skill to the hospital, and also get to provide hospital on-call and hospital ward and emergency department management. And I guess the upshot of that is they get to continue to consolidate their AST while completing their general practice training. So one of the concerns that some of them have is they have to kind of essentially put their AST on pause while they go and do their general practice training, and then come back and try to pick it back up again. So working here allows them to do both. Um, from a health service point of view, we've seen an increase in our average employment tenure. We've seen an enormous decrease in our external labour costs. Longreach itself has been free for locums for 17 months. I should say there is a little exception to that. We decided to host a maternity conference here back at the start of April, and we deliberately made the decision to get a locum in just for 5 days to cover the guys so that they could attend the conference on home turf. We felt that that was important for culture and showing that we what we think what they do is important. So technically not free for 17 months, but really in practice we've been free for a long time. It's increased our number of GPs. It's obviously increased access to general practice appointments. It's provided additional service delivery options. So we do First Nations clinics. We've got a First Nations doctor on our staff here in Longreach. We've got through pre-anaesthetic ones, and we've now just opened a renal dialysis unit open here in April. So a new service for us to staff. We've got decreased fatigue and we've got positive workplace culture survey results. So this is what I do. I've got this little hobby where I like mapping data. I know it's probably fairly small, but I decided on my January holidays, I don't particularly like the sun or the ocean or sand. And so when we had a beach holiday, I decided to map the workforce again, going back to the start of 2011. And so I gave every doctor who'd worked within the health service a line, and I translated it into a average employment tenure, which has got an artifact in it. So anyone who's a mathematician will know that you've got to start somewhere. So there's an artifact right at the beginning, but you can see that our average tenure here in Longreach is creeping up close to 4 years, which is amazing because when I started here, it was probably about a year for most registrars in particular. When we did our survey results, we decided to, as a health service, to move away from the traditional Queensland Health survey. Queensland Health did this Work for Us survey, which was really long, pretty dreary, had very low completion rates. And we switched to a private provider of our culture survey last year. I was really pleased to see that we had an 87% response rate within the medical workforce to the survey. So I was pretty happy with the validity of some of the results. And actually, to summarise, what it really showed was something that I've said all along. I often tell people when I'm asked that I came for the work and the type of work we do as rural journalists, but I actually stayed for the community. And I certainly Paul made that point at the SEM conference, is that I've started to look at measures of what is actually showing to me that people are embedding themselves in the community. And I'm making a little list, which is really hard to measure, but certainly when people start to buy their own home, even when they're provided with free accommodation, but they make the decision to buy their own home, for me, that's a real sign that they're actually embedding themselves in the community. And then in last month, we had our Longreach show. And I think there was probably 6 or 7 doctors from Longreach who won awards across the show, across sewing, crochet, gardening, photography, Lego even. Which really to me showed that not only were doctors had time to have a work-life balance, but they were also really keen to contribute back to the community, because the shows don't occur unless people make the effort to actually submit entries. And so it was amazing to see, and really one of those kind of funny things that made me reflect on where we've come. So these attraction reasons you'll see are all really about the type of work and about the employment remuneration, etc. But why people stayed is more about the community and about being able to continue to provide what they do and provide some good. People want purpose in what they do. And I think that's what our survey really showed. I am actually working on a different set of measures, but which is actually to try to tell me about how healthy our workforce is. And so I'm trying to look at some measures that actually give me some more objective stuff, like how often people are taking professional development leave, how many hours a week people are working on average, how much overtime people are doing, how much fatigue they're incurring. All of those kind of things might give me an indicator about when I can be happy that I've got enough doctors. Anyone who's a gardener out there will recognise that this is this concept of layering, and I think it's not rocket science, but I guess it's something that we like to describe as how we try to build our workforce. I think no junior doctor these days wants to come to a small town, hang up their shingle and start practicing independently. I think the reality is that most of them want some support. And whilst the Rural Generalist program was initially set up with the concept that people would come out and be independent with their advanced skill, the reality is that most of them need to take some time to consolidate their advanced skill, to get their general practice training done, and then to be comfortable in their own skin. And I think for us, it's about being able to do that, provide support and seniority. And it doesn't happen overnight, but what we found is that as Claire and I stayed, and then as the next set of doctors stayed, and all of a sudden they've been here 8 years, the next set down have been here 6 years. And in layering in from a gardening sense, you could then cut the tie between those plants and they'll survive on their own. So we thought it was a nice analogy to what we try to achieve. And that's one of our proteges. This is Curtis. His mum happens to be a remote area nurse in one of our PHCs here in the Central West. She was a PHC Director of Nursing when Claire and I started here as registrars, and that's her son, Curtis. And he is in his second year now, practicing, and wants to come back to the Central West as a rural generalist. And certainly across our workforce, I did a quick rough count. I think it's 55% of our workforce in the Central West were here as students or junior doctors at some point in their earlier career. I'm not really keen to kind of stop improving this. I'm really think we're not quite there with some of our workforces. And whilst things are pretty rosy in Longreach, the reality is that in Blackall, I haven't quite gotten there. I've got 2 permanent doctors across a workforce of 4.5, and I'm still very much locum dependent there. So I was born a pessimist, and so for me, I'm always looking at how I might be able to make things better. For me, I want to start looking at some general practice performance metrics. How can I actually show that what we're doing is making a difference? We've actually got a really unique opportunity, I think, because we control, in inverted commas, both the primary and acute care settings. I think we've got an opportunity to actually show that what we're doing in general practice can make a difference. I'm thinking of looking at things like discharge, readmission rates post-discharge, how long it takes patients to get an appointment post-discharge, but also looking at actual health measures. Like, are we actually improving health outcomes by controlling general practice here? I'm almost finished. This is a very raw slide. These are things that we're looking at to try to look at. We've got 4 pillars that we're basing our general practice on. So quality, access, finance, and systems. And this is just a raw list of things that we've put under there as things we might potentially measure. Some obviously are much harder to measure than others, but we're going to start picking out a few from each pillar and actually work on a performance dashboard that we can start showing to, firstly, our general practice leadership team, but obviously our executive more at a higher level, and then the board once that becomes more mature. So I guess in summary, it's a model that delivers care, a continuity of care for us. It's worked for us. I really don't think it will work for everyone in every corner of the place. I'm very much like Paul. I love learning about other models and how they work. But this has worked for us. It's potentially scalable. And I guess it's now got some runs on the board in that it's proven. So I might end it there. I don't have a question mark slide after this. So I might stop sharing, but happy to open to the floor for questions.
David, Ananingi, thank you. Fascinating to see what you've developed there. An entirely public system covering both primary care and hospital care for a whole region. I was trying to do the sums, and I think you said 26 FTE, and you have about 11,000 people. So that's about 1 doctor for every sort of 420 people, which is still a lot less than the Australian average, which is around about 4 doctors per 1,000. So 1 doctor per every 250 people. Now, of course, you're not delivering neurosurgery and all of those specialty tasks that take an enormous number of doctors to provide. But do you have an idea of the sort of ratio that you're wanting to get to for your population?
Yeah, definitely. I think in general practice, Paul, if I'm correct, my data might be a bit light, but when you look at general practice alone, it's still kind of sitting around 1 per 900 or 1 per 1,000, I think, from memory. And when you go rurally, it's usually a lot less than that. Don't hold me to those figures, but I did some modeling on this. I have done some modeling, look at a whole range of things you could do, including how much call you provide and what percentage of general practice but I think I'm aiming at around 1 to 300 is roughly where I'm wanting to head. To give you an idea, just for context, so back when this was a medical super with right to private practice model, Winton, which is my northernmost town, had one doctor. Longreach had two doctors. Blackwell had one doctor, and Buckhaldern had one doctor. And so now Winton's got 3 positions, 2 of which are filled. Longreach has got 10 positions, and there's 13 doctors working across those 10. Buckhaldern's got 6.5 positions, and it's got 8 doctors working across those. And Blackwell's got 4.5 positions, and got just the 2 permanents at the moment. So we're getting there, I guess, but we had to really change things. It's kind of, people often say, oh, why do you create more positions when you're not fully filled? And I guess it's that kind of field of dreams. If you build it, they will come kind of stuff. We've got to have the practices set up to be able to employ people.
Yeah, no, you're quite correct in terms of the general practice numbers, but to that sort of 1 in 900 or 1 in 1,000, you then have to add all the non-GP specialists and all the trainees. And our trainees make up 25-30% of our workforce, total workforce in Australia. So I think that's where it sort of comes down to that overall figure. And your statement that in Claire's year, she was the only one who ended up working rurally. For context, I would imagine that University of Queensland had, 250 students in its year at least at that stage?
A little bit less, about 210. And to give you the listeners an idea, my mother graduated from University of Queensland in 1976 as a mature age previous nurse and midwife, and went back and did medicine. But it also graduated 210 in 1976. So it didn't change from when Claire and I graduated in the very early 2000s from when my mother graduated in 1976.
But the number who went rural certainly changed. It went right down. So there is that missing generation of rural doctors that we are having the frustration of. The other question I had was, you mentioned the fact that you don't get any state funding for the essentially outpatient work that you're doing. Have you ever considered stopping the Medicare and moving to an outpatient model of care?
We've considered it. I guess culturally we'd made the early move away from that. So back under the original MedSup with right private practice model, they actually used to have to run a general practice outpatients, but it was run within the emergency department with not the right equipment, not the right setting. And so we actually delivered into kind of purpose-built general practice environments. And so the other thing is, because we're block funded, I'm not necessarily convinced that even if we reported all activity from general practice as an outpatient activity, that we would turn it into funding. We certainly haven't had that kind of promise from the department.
Right. Yes. So you would have to be activity-based funded, correct, for that to make. Wayne, you probably know more about this than David or I. You want to make a comment?
Yeah. The problem is that when you move away from Medicare, then anyone that would be on a care plan loses the access to other services like private allied health services that they could get as part of that care plan. So moving away from Medicare actually restricts your patient's ability to access other primary health services, which is a reason to Medicare bill for primary health, even if you could count it as IPF.
It's a great point, and it's actually something I didn't touch on, that in the Western Corridor, the general practice service for all of those patients comes from the Royal Flying Doctor Service, who do fly in, fly out. But because the Royal Flying Doctors is Commonwealth funded, they can't access Medicare when they provide the services. So as you say, all of those patients are not able to access Medicare to get allied health services. And secondly, we lose our most reliable way of measuring, the Australian Institute of Health Welfare. Obviously, that's one of their major data points, is what Medicare items are being billed. And so all through our Western Corridor, we're not actually generating Medicare item numbers. And so it's very hard to track chronic disease progress, all sorts of things. And so we're actually working with the PHN to see whether we can do an outreach model to the Western Corridor. but it's in its very early stages, and I don't want to panic the horses, spook the horses. Don't want anyone to think that I'm getting rid of the RFDS service, because I'm not. So if the RFDS is listening, please be calm. But it is a problem. I totally agree with you, Brian.
Now, I need to leave. I'm the CEO of the LHA, and I do want to thank you, David. But I'll let you carry on with everyone else. I've got another meeting I need to get to.
Thanks, Wayne. Thank you very much. And I realise we're just on 2, but I'm certainly happy to. My first patient's at 15:15, so I've certainly got a few minutes to answer some more questions if there is any.
So if there are any questions from our junior doctors or other staff, I was interested in the tenure has increased from 1 year to 4. That's a remarkable return on investment, I guess.
Oh, it is, isn't it? I mean, I think any of us who are in these kind of senior management roles would know that it's the dire hamster wheel of recruitment. The more time you can spend off that hamster wheel, the better. And obviously, it's a little bit difficult to measure, but certainly it's much cheaper to have someone in a role than it is to be constantly recruiting. I would say, however, I am very big on culture, and so anyone who I don't think is a cultural fit, I would really rather an empty house than a bad tenant. So it is important to me to make sure that we've got the right mix of people to generate that culture.
So how do you go about that selection process?
But I think, to be honest, I actually don't. I don't rely on formal interviews as anywhere near as much as I used to. There are obviously every state's got selection criteria, and we've all got probably a recruitment policy. Ours is called B1. I've seen too many people who are train wrecks in interviews who turn out to be wonderful, wonderful employees, and conversely, people who are absolute professional at interview but turn out to be a bad cultural fit. And so I think one of the things we've tried to do with our rural journalists is we get them to fly out. If they end up working for us, we refund their flight and their accommodation. But we get them to come out and we get them to spend a day on the ground. And I'll clear my diary and I'll spend the time with as many senior staff as I can to take them around the health service and actually just get to know them, but also get to know what they're in for. And I think it's really important. The other really important one is students. I cannot understate how important to us the student pipeline is. It's just, in the whole time I've been here, we've only recruited 2 people from a traditional job interview. Almost everyone else we've recruited has been from kind of networks, word of mouth, and from the student kind of experience, because I think they get to experience what we do. They get to see the good, the bad. They get a realistic view of what working here would be like. And if they want to work here, we do our damnedest to actually make sure we've got a spot for them.
Yeah. Look, some wonderful wisdom there, David. Thank you for sharing that with us. I'm struck by your comment. Better an empty house than a bad tenant, and I think we've all been there, both literally in terms of having neighbours who are bad tenants, and also figuratively in terms of the health systems that we work in, and knowing how long it takes to undo a less than ideal selection process. So, congratulations on the way you've been able to look at that process being a much more personal and clearly effective selection process. But of course, it's only effective if you can afford to say no. And it sounds as though you're now in a position where you are much more able to say no and select the best, rather than where you were 15 years ago when it was an absolute crisis. So congratulations on that.
Look, I don't want anyone to think that I'm just a dictator that pushing people away that want to work here. I think it's just I just really think our job's hard. Rural journalism is hard, and I think in the past there's people who just go, oh, that's the job for people who can't do anything else. It's the job for people. You're really good, and I see students who go, oh, Paul, you're really good at internal medicine. You just need to become a physician. You know, you should think of becoming a surgeon. But I tell our students, you know, if you're interested in everything and you're good at this stuff, then you should think of becoming a rural journalist because it's the hardest job. Come here, we'll look after you, we'll pay you well, but don't think it's easy and don't think it's suited to everybody.
What a great way for us to leave. Ananingi, David, and Ananingi to everyone as part of this grand round, whether you're watching and listening now or in the future. Thank you for being part of the Riverland Academy of Clinical Excellence, and we'll be joining together again in the next fortnight. So, Nakan, everybody.